everyone. This is Dr. Aisha Khan, and the topic for today's session is going to be imaging in the Mullerian anomalies. So I'm really happy that you guys are here, though it's a weekend. But if you have decided to put other things aside and be here today in this session, so I'll just request some minutes of undivided attention. So try to cut off all distractions, just sit back comfortably, relax, and listen. That's all you're expected to do. Baki notes you will be getting this entire PPT. I will be sharing with you. And future may also, if you have any queries, then I will be leaving my contact details at the end of the session. So I hope for everyone the audio and video is fine. And just let me know if you guys are comfortable with English. Can we use a little bit of Hindi here and there for explanation? Just let me know, guys, if Hindi works. Otherwise, we'll try to do it in absolute English. Okay, so chalo theek hai. Let's start with this. So what I feel that as a resident, when I used to have these cases of Mullerian anomalies, okay, so hello everyone. I extend a very warm welcome to today's session. So I'm Dr. Aisha Khan, and this is my first session at this platform, though I have been teaching on-site and online for over a decade now, and I'm really passionate about medical education. So this is my ultimate passion. I want to extend my heartfelt gratitude to Dr. Zainab Vora ma'am and the entire team at Conceptual Radiology for giving me this exceptional opportunity to be able to give back to my juniors. I ensure that if you give me some of your time, I will be leaving you much more confident and excited about diagnosing these cases of Mullerian anomalies in your day-to-day practice. Okay? So the agenda for today's session is going to be a warm welcome, which we have done. Then the why. The next topic will be embryology. Okay. So embryology we will discuss because that is the basis of Mullerian anomalies, guys. ठीक है? So embryology की अगर हमें understanding हो जाती है, so we will be understanding everything else, that why a particular anomaly is happening, and we'll also be understanding that there are some rare anomalies. Okay, so why do they happen? We'll be able to understand that as well. The next thing will be the toolkit that we have as a clinician. Next would be dimensions for life. Then we will be discussing about classification systems, the ASRM, that is the American group, the European group, and the QMA classification. After that, we will be discussing about individual types of Mullerian anomalies in detail. The saga of septate will be a short story. Then some pain points in everyday reporting, this versus that. A lot of confusion is there about whether to diagnose at biconjugate or septate. So that will be addressed further. Then finally, I will tell you an algorithmic approach that next time when you are in your OPD and a case of Mullerian comes, so how will you ultimately approach that case? Then we will talk about reporting. If time permits, I have a mini quiz for you guys to test our knowledge at the end of the session, and we will be ending with some words of wisdom. Okay. So firstly is the why. Okay, so why Mullerian anomalies? So there is a threefold answer to that. Number one, because from the theory point of view, we can expect a long answer question in our theory exams in MD and DNB. Secondly, practical may you get every single time you get at least one spotter from Mullerian anomalies. They can show you HSG image or a 3D ultrasound. And thirdly, in your private practice or while you are working as a resident, there are quite a few cases you keep getting in between, especially at our center, which is linked with an infertility clinic, a dedicated infertility clinic in OBGY department. So we get quite a few cases of Mullerian anomalies every now and then. Okay, so that answers the why, that why Mullerian anomalies, theory, practical and practice. So now why का एक और पहलू ये है that why is it so important for the patient? Because number one, it is associated with certain adverse reproductive outcomes, so OBG aspect of it. Second is the gynac aspect of it, that is infertility, implantation issues happen, endometriosis, adenomyosis, things like that. But keep one important thing in mind, that Mullerian duct anomalies do not prevent conception. Conception will happen, but that pregnancy may have a really poor outcome. There may be malpresentations. There might be ectopic pregnancy happening, like in cases of rudimentary horns. There might be IUGRs, abnormal presentation and lie. Okay. And there could be second trimester as well as first trimester abortion. So usually these women present with recurrent abortions, a poor obstetric history, secondary infertility, and sometimes even primary infertilities. But keep this in mind. The pearl of this slide is that anomalies like this do not prevent conception to happen. Okay. Acha, so it is not just related with the pelvic anomalies, it is also associated with a myriad of other things, such as renal, skeletal, cardiac, and even some syndromes such as Klippel-Feil syndrome. Renal is so characteristic and everyone remembers because our Mullerian duct and the development of the collecting system in kidneys that happens in conjunction with each other. Okay, so always look out for kidney. I think this is one of the reasons that every pelvic ultrasound is incomplete if you have not commented upon both the kidneys and the collecting system. So make it a dictum for life that anytime Mullerian anomalies, so have a holistic approach, look for the kidneys, any skeletal anomalies, cardiac anomalies, and some syndromic presentations as well. ठीक है. अब हम बात करेंगे एम्ब्रियोलॉजी की. अगर हमें एम्ब्रियोलॉजी समझ में आ गई, then we are good to go for the entire session and also for life. So firstly, तीन चीजें होती हैं. Okay, we have the gonads. Then in women, right now we'll restrict ourselves to the female reproductive system. So we have the gonads, which is ovaries. Number two, we have the Mullerian ducts. And number three, we have the structure called urogenital sinus. Okay. So these are my gonads. Yep. And in this, you can see that we have the paramesonephric duct, which is the Mullerian duct, and lower down we have the urogenital sinus. Okay, we have the urogenital sinus. Okay. So gonads will develop from the genital ridge. The Mullerian duct will give rise to number one, uterus, number two, fallopian tubes, number three, cervix, number four, upper two-thirds of the vagina. The lower one-third of vagina, along with bladder and urethra, is coming from urogenital sinus. So gonads, number two, Mullerian duct, and number three, urogenital sinus, giving rise to ovaries, the entire uterus, tube, cervix, upper vagina, and finally the urogenital sinus, giving rise to the lower part of the vagina. Right. सो दिस इज लाइक अ टाइम स्टैंपिंग के कौन से वीक्स पे कौन कौन सा मुलेरियन डक्ट का और उस पूरे सिस्टम का डेवलपमेंट होता है. तो वी स्टार्ट एज अर्ली एज 4 weeks. एट 4 weeks, then it is like your multiples of 2. 4 week, 6, then 8, then comes 10, but actually 10 को ड्रॉप कर दो, then you remember 12. तो 4, 6, 8, 10 को ड्रॉप करिए, 12, and then finally term. Okay, so 4 weeks पे you have the development of two Mullerian ducts. Okay, ठीक है, they are widely separated though at this time. 6 weeks पे there starts medial migration of these two ducts. By 8 weeks there is fusion of the two Mullerian ducts. Okay, अब फ्यूजन पे जो हमारी प्रीवियस अंडरस्टैंडिंग थी, दैट वाज फ्यूजन हैपेंस इन वन डायरेक्शन, यूनी डायरेक्शनल फ्यूजन. दैट मींस, what do you guys think? The fusion occurs cephalic first and caudal, or it occurs caudal first and cephalic later on? Can you just quickly write down in the chat? What do you think is the direction of fusion? Is it caudal to cranial or otherwise? Okay, so the direction is actually caudal to cranial. So this is the reason you have your bicornuates, right? So bicornuate में आपको क्या दिखता है? Bicornuate, yes, very good. Manisha, absolutely on point. तो सबसे पहले lower part का fusion होता है, and जो upper part होता है वो फिर भी divergent रह जाता है. The proof is a bicornuate uterus, which is fused partially. The lower aspects are fused, but upper aspects are separated and divergent. तो caudal to cranial होता है. That is the primary thing, unidirectional mostly. But because some rare anomalies come and there were a lot of case reports, तो फिर से committee ने बैठ के रिसर्च करी and they found out that the primary thing is caudal to cranial, but a small element can happen in the second direction also. Something can happen in cranial to caudal also. So it is actually a bidirectional fusion. Okay, जो कि recently research से पता चला है that it is actually bidirectional. But the primary component is no doubt caudal to cranial. Okay, तो ये चीज होती है 8 weeks पे. Right. Now, if this fusion is happening, then what will happen? Fusion के बाद next thing, there has to be septal resorption. A little bit of a technical issue is happening. I don't know why the next slide is not coming. Okay. So at 12 weeks, 10 को हमने ड्रॉप कर दिया, 4, 6, 8, 10 को ड्रॉप करा, 12. So 12 weeks पे क्या होता है? Just look at this. इस वीडियो में और आज के बाद आप भी ऐसे अपना हमेशा इमेजिन करोगे. So this is one hemi uterus, this is another hemi uterus. They have to come in the midline. Now if they come in the midline, you can see this. There is a common wall. जस्ट लाइक दो नेबर्स रहते हैं और दोनों के बीच में एक कॉमन वॉल होती है. तो अगर आपको पूरी तरीके से दोनों घर को यूनाइट करना है, so you have to break and get rid of this common wall. So you have to get rid of these fingers, that means the septa. So septal resorption and recanalization has to happen to get a beautiful patent uterine cavity, a cervical cavity, and a patent vagina as well. So these are the two hemiuterus. They will first migrate, then they will fuse together, and you have to get rid of the septum in between, that is septal resorption. Acha, it is not only longitudinal septum, mind you, we remember that upper part of vagina and lower part of vagina, they are also developing from two distinct structures. So a lot of times there are some transverse septa in the vaginal cavity also. So you have to get rid of all longitudinal septae as well as get rid of all transverse septae. So that process of septal resorption involving longitudinal septal resorption as well as all the transverse septal resorption will be around 12 weeks. And finally, at term, we will have this beautiful uterus with the tubes, with the cervix, vagina, the cavity is patent, and everything is normal in size, shape, and structure. Okay, so this is the normal development. Right. Now, at each step, now because we have understood this entire process in a chronological order, अब हर step पे एक anomaly आती जाएगी. तो Mullerian ducts ही अगर form नहीं हुए, तो bilateral ducts are absent, complete Mullerian agenesis, which is called your MRKH syndrome. If one duct is formed, then unicornuate uterus, and the second duct may be rudimentary, so rudimentary horn. Second step tha fusion. So if fusion is not happening, so you get two separate hemiuterus. That means bicorporeal type. Okay. Next step mein, if the septal resorption is not happening, if the septa is not getting resolved, so you can have a septate uterus, you can have a septate cervix, and you can have a septate vagina as well. That is a longitudinal vaginal septum or a transverse vaginal septum at this level, if resorption of septa is not happening properly. And last में 12 week के बाद term तक subtle anomalies हो सकती हैं, which can cause a little bit deviation in the shape of the uterus, like a T-shaped, an I-shaped, or an arcuate uterus for that variety. The subtle anomalies happen later on. Most severe, Mullerian agenesis, सबसे early. Later on, subtle anomalies such as arcuate, T-shaped uterus, etc. Okay. So now we have the toolkit. Okay? So what all tools we have at our discretion to diagnose these cases? उसमें we have to start always with a gynecological examination. ठीक है? Always and always start with a good gynecological examination and proper clinical history. Unless and until you know the history, examination findings, touch the patient. ठीक है? So first and foremost, everything has to be in this order only. So you start with a good gynec exam and a detailed history. ठीक है? Is it primary infertility? Is it secondary? How many years? Is it a chronic thing? Is it an acute thing? And is there dysmenorrhea? Everything. Is there endometriosis, adenomyosis? Are there recurrent abortions? In which trimester? Has she ever undergone previous treatments like a septal resorption? You never know. So unless and until you ask the patients, they won't tell you. So history and examination सबसे पहले. Second is हमारी conventional method such as an HSG. Now in our department, what we prefer that we always do a 2D scan first, a 2D pelvic ultrasound, then we date the patient and give the date for an HSG. Okay, and you remember the day 10 rule. 8th to 10th day is the preferable time to do an HSG. After that, there is always this tool with us which is called as 3D ultrasound. ठीक है, or 3D ultrasound may I have written as prep because there are some tests in radiology which require preparation. One of them is actually 3D ultrasounds, though it is not usually done because there is a rush and there is a lot of pressure that just diagnose it and let the patient go. And the gynacs also say, quickly give us the reports. I know that all happens in real life, but in an ideal world, it is best to do a 3D scan with preparation. And that preparation is called as endometrial preparation. Ideally, 3D scans should be done in the luteal phase when you have a beautiful, thick, properly developed endometrium. Okay, some people even go forward and give some mucolytics before they perform their 3D scans. Okay, 3D sono. Okay, next is MRI. So MRI is actually our gold standard and it is also a problem solving tool. However, recent में some studies have been done which show कि 3D ultrasound, a good 3D scan and MRI are very much comparable as far as sensitivity and specificity is concerned. Okay, yeah, so don't worry bachcho about HSG. We will be coming to HSG, but HSG in itself is a huge topic which we might be taking in a separate session in detail. HSG and all the presentations which can happen. Anyways, till then, we have everything written in the slides, a lot of things, so don't worry about the annotations part right now. तो MRI हो गया, ठीक है. So ये normal चीजें हैं और इसी sequence में we should go about it. A gynec exam, HSG, or you can do a 2D first, HSG, 3D, and then you have your MRI as the problem solving tool, and it is also the gold standard with a very high sensitivity and specificity. However, I tell you that 3D ultrasound is also comparable in sensitivity and specificity to an MRI. But MRI में main ये चीज है that there is multiplanar reconstruction, plus there are some things which only an MRI can tell, such as what kind of septa, is it fibrous, is it muscular, the endometrial cavity, functional endometrium, rudimentary horns. So there are certain things which you can see best on an MRI. Okay, otherwise a 3D ultrasound is good to go. ठीक है, इसके अलावा we have some other tools. अब हमें पता है that in real life, lot of us when working in government setups and resource depletion, we have to do jugaad. Okay, so the real thing is jugaad. These are the tips which no one else will tell you. So it is that every time, say you don't have a 3D, or by chance you have a female who's not sexually active, an unmarried female, so you cannot do your transvaginal 3D or 2D transvaginal. Then what do we do? So in these cases, we have to try everything best that we have. So we can get, if she is consenting for a transrectal scan, go for a transrectal. Otherwise, you can try a transperineal scan in this. तो ये हमारी जुगाड़ वाली भी चीजें हो गई. अच्छा, then are some invasive things such as hysteroscopy and laparoscopy. ये यूजुअली तब यूज करते हैं वेयर वी हैव इनकंक्लूसिव डायग्नोसिस विद MRI also. If we are not able to come to a conclusion, then we can go for these invasive things. And a novel technique is your 3D sono saline infusion hysteroscopy. So this is the very typical HSG. HSG का जो primary role होता है, that is tubal patency. So HSG's primary role is never about Mullerian anomalies. All it can tell you is about the uterine cavity, the shape of the cavity, right? So it cannot actually characterize that if the cavity is present indented, okay, अब it is bicornuate or was it septate. The fundal contour it cannot see. This is the reason that HSG पे all you can see is the tubal patency and you can see the cavity, the shape of the cavity. Okay, these are the things which we can see on an HSG. Now we have a 2D ultrasound. So 2D ultrasound pe we can very confidently diagnose things such as hypoplasia and aplasia. We can confidently tell about didelphus and we can also tell about complete bicornuate uterus. Okay, then comes 3D ultrasound. 3D ultrasound mein we all know that it is a very beautiful modality. You get these coronal 3D rendered images. इसमें you see everything. You see the fundal contour, you see the endometrial cavity, you can measure the wall thickness, the external indentation as well as the internal indentation. Almost everything you can get on a 3D. Okay? So these are some images. Always a good 2D precedes a 3D. So 2D pay you have the long axis view, transverse, coronal, and then you have the reconstructed images. Okay, this is an image of a transperineal ultrasound which we had to do for a case because the female was unmarried. So all the tools that you have, make the best use of them. ठीक है. MRI का क्या रोल होता है? Characterization, especially septate uterus में, because that is the most common anomaly, and you always have to characterize, is it fibrous, is it muscular, or is it fibromuscular, because that depends. आपकी जो रिपोर्ट है और आपने जो सेप्टा का कैरेक्टर बताया है उसी हिसाब से द लैप्रोस्कोपिक सर्जन विल गो ऑन टू रिसेक्ट इट और लीव इट कंप्लीटली. Because ever just remember always that if you are resecting a muscular septum or myometrium, it is always having a grave prognosis. But if you are resecting a fibrous septum, then it is something very simple and safe to do, and you can improve the reproductive outcome for that female. This is a 3D cis image. Right, so we have discussed the basic things. Now we come to dimensions for life. These are some measurements that we should take, and they will help us a lot in correct diagnosis. Okay, so most of the measurements are on a 3D scan, but they can be interpolated to MRI, some of them to a 2D ultrasound, and some measurements you can also apply to your HSG. Okay, तो ज़्यादातर measurements जो हैं वो 3D अल्ट्रासाउंड के लिए बताए गए हैं. ठीक है. Now I have to draw here, so let's try if it works. Yes, चलिए. So सबसे पहले हम ये वाले यूट्रस देखते हैं. A image. Oh my god, this is the normal uterus. ठीक है. A image is the normal uterus. तो इसमें आपको कुछ एक्सटर्नल देखना है. What is external? External is a fundus. Sorry. So this is my fundus. It is appearing very beautifully convex. Okay. Then what do you have to see? Internal is your endometrial cavity. So this is a normal triangular shaped endometrial cavity, and the fundus is convex outwards. Okay. So just remember some things, that fundus is called the serosal surface, the fundus or the serosal surface. Okay. And normally the fundus is convex or it is having a bulge outwards. That is the normal thing. Now, if you have an abnormal thing, what can that be? You have a fundal cleft, heart shaped. Okay, so fundal clefting or external indentation, these are the problematic things. So normal is convex or a little bit flat. It is called as the serosal surface or the fundus or the fundal contour. And when it is problematic, the moment it starts to dip inwards, then it is called external fundal clefting or external indentation. Okay? So external fundal clefting or एक्सटर्नल इंडेंटेशन. एक्सटर्नल इंडेंटेशन ये एक चीज हो गई आई. ठीक है, ई वाला चीज. दूसरी चीज होती है आई. व्हाट इज आई? आई इज द इंटरनल इंडेंटेशन. if you look at this cavity, this is very flat, there is no indentation. Indentation means impression or dipping. ठीक है, but if we look at this cavity, this is quite indented. So this is internal indentation. Internal means the endometrium or the mucosa or the cavity. External means the fundus or the serosal surface or the fundal contour or the dome of the uterus. Everything is same. Internal bole to cavity, endometrium, mucosal surface, that is everything internal indentation. External bole to fundus, fundal contour, external clefting, external indentation, bulging, everything is to do with the serosal surface or the external aspect of the uterus. Okay? And everything in between, external and internal, everything in between is the myometrium, because the uterus has 3 layers: the inner mucosa or the endometrium, मिडिल में जो मेन उसका वॉल बनाती है, दैट इज द मायोमेट्रियम, एंड एक्सटर्नल और द सेरोसल सर्फेस which is the fundus right now what we are discussing. So everything between the serosa and mucosa is the myometrium, which is called the uterine wall thickness, that is T. तो ये तीन चीजें इस पूरे लेक्चर में हम मेजर करते रहेंगे. वी विल सी द एक्सटर्नल इंडेंटेशन, इंटरनल इंडेंटेशन एंड द वॉल थिकनेस. EIT like eat. ओके. एक्सटर्नल इंडेंटेशन तभी लेना है जब क्लेफ्टिंग दिखे हार्ट शेप्ड में, यानी बाइकॉर्नुएट में या डाइडेल्फिस में. ओनली देयर यू हैव द कॉन्सेप्ट ऑफ एक्सटर्नल इंडेंटेशन. बट इंटरनल इंडेंटेशन एंड यूटेराइन वॉल थिकनेस वी कैन मेजर ऑलमोस्ट एनी केस. ठीक है. So this is a normal uterus. Now if we look here, this is a subseptate variety. तो इसमें सारी चीजें समझ में आएंगी. Then you have some lines, and lines में the first and foremost is your interosteal line. Interosteal line is everything. You start with this. कभी भी you get a 3D scan or an MRI, you just drop the interosteal line. So this is the highest point of this. यहाँ से fallopian tube will start. इधर पे fallopian tube will start from here. So these are the two ostia, and you draw a line connecting the two. So the distance between the two is the interosteal distance, जो कि हम HSG में भी लेते हैं. And if you have a complete through and through line, that is called as the interosteal line. है ना? Interosteal line. Some people can call it by different names, such as intercornual line or interstitial line. ठीक है. They can call it intercornual line or the simply interstitial line. सारी चीजें एक हैं. सबसे एक्यूरेट टर्म है interosteal line, connecting the two ostia together. That is interosteal line. Every time your measurements have to start with the interosteal line. Second step क्या होगी कि you look at the deepest dip. What did I say? Deepest dip. किसका? एंडोमेट्रियम का, जिसको टेक्निकली बोलते हैं एपेक्स. सो यू लोकलाइज द एपेक्स. तो यहाँ पे एंडोमेट्रियम इज डिपिंग एंड दिस इज द पॉइंट ऑफ डीपेस्ट डिप. सो यू ड्रॉ अ लाइन अलोंग दैट. So this is the line which is along the deepest dip or the apex. And third thing, you draw a line along the highest hump. Highest hump. What is the highest hump? It is actually the external fundal contour, जिसके बहुत सारे नाम है. फंडल कंटूर और द सेरोसल सर्फेस. हाईएस्ट पॉइंट ऑफ दैट, माइंड यू. ठीक है बच्चों. सो हाईएस्ट पॉइंट हमारा ये हो जाएगा. हाईएस्ट हम्प विल बी समवेयर हियर, द सेरोसल सर्फेस. सो फर्स्टली इंटरऑस्टियल लाइन, देन डीपेस्ट डिप, उसके अलोंग एक लाइन, हाईएस्ट हम्प, उसके अलोंग एक लाइन. ठीक है. अब हमने लाइंस तो बना ली. ठीक है. तो एक्चुअली इसके अलोंग लाइन ड्रॉ करनी है. तो ये आपकी एक हाईएस्ट हम्प वाली लाइन हो गई. ठीक है. So this is the interostitial line, number 1. Number 2 is the line along the apex or internal indentation, that is the deepest dip, and the third is the line along the highest hump. Okay. Now we have to simply draw perpendiculars. If you draw perpendicular between line 1 and 2, that will give you your internal indentation. Cavity कितना अंदर तक जा रही है, internal indentation. And if you draw a perpendicular between line number 1 and 3, what do you think? ये आपको क्या देगा? So without a doubt, this will give us the uterine wall thickness. Because मैंने आपको बताया है कि external indentation का जो concept है वो तभी आएगा जब clefting मिलेगी. यहाँ पे तो कोई clefting नहीं है, यहाँ पे तो एक smooth fundus present है. तो यहाँ पे तो external indentation हो ही नहीं रहा, तो हम measure क्या करेंगे? तो measure, we just have to measure the internal indentation in this case and the uterine wall thickness. So this is my internal indentation and this T is my wall thickness. So why have I chosen this wall only, the fundus? Because that is the standard protocol, that I have chosen this fundal wall. If I want, I can choose the lateral wall also, right? This is the right lateral wall and this is the left lateral wall. You can choose anything. But what the standard protocol says, let's try to follow that. Let's be very strict while taking measurements so that बाद में we are not having a confusion कि septate है या bicornuate है. So जब भी measurements की बात आए, let's be very strict. Number 1, interosteal line. Number 2, deepest dip. एंड नंबर 3 हाईएस्ट हम्प, तीनों के अक्रॉस आपको एक लाइन बनानी है। तो इंटरऑस्टियल लाइन से डीपेस्ट डिप इज योर इंटरनल इंडेंटेशन एंड इंटरऑस्टियल लाइन से हाईएस्ट हम्प इज माय wall thickness. This wall thickness, to be specific, is the fundal wall thickness or the anterior wall thickness, because in an antiverted uterus, which is the normal variant, antiverted uterus mein the fundus is present anteriorly, so it is called the fundal wall thickness or the anterior wall thickness. If we want, we can measure the lateral wall thickness also by drawing perpendiculars, so that will give us the lateral wall thickness if we want. ठीक है, अब हम इस वाले एग्जाम्पल को देख लेते हैं. दिस एग्जाम्पल हियर वी सी दैट इट इज बिकमिंग लाइक अ हार्ट शेप्ड कैविटी. तो हियर वी कैन मेजर द एक्सटर्नल इंडेंटेशन. द फर्स्ट एंड फॉरमोस्ट विदाउट एनी कंफ्यूजन हम ड्रॉप करेंगे इंटरऑस्टियल लाइन. सो दिस इज वन ऑस्टिया, दिस इज अनदर ऑस्टिया, अ लाइन कनेक्टिंग द टू ऑस्टिया विच इज माई इंटरऑस्टियल लाइन. This is the highest hump over here. This is the highest hump over here. So connecting the two lines of the highest hump. This is okay, understood. Now what is this giving me? Interostitial line and highest hump. This will give me the wall thickness, because ये हमारा mucosa है, ये हमारा serosa है. So mucosa and serosa के बीच में we have the wall thickness. Okay, and interostitial line and deepest dip. This is the deepest dip. So what will this give me? This will give me the internal indentation. What about external indentation? तो यहाँ पे जो ये cavity, heart shaped cavity कहाँ तक dip कर रही है? It is coming till here. So this cavity is coming till here. So I draw this line where it is dipping. Okay, and this is the expected site where it should be. So here actually wall thickness जितना है उतना ही इसने dip कर दिया है. So here almost same दोनों का measurement आएगा, but the method is what I wanted to explain. Okay. We have many more diagrams to come, जिसमें if we have any doubts they will get cleared. Okay, so this was this concept. Yeah. Okay guys, so we are discussing about 3 concepts, very simple, no worries. Number 1 is internal indentation, then external indentation and the wall thickness. ठीक है, so internal indentation means the dipping of the endometrium. External indentation means it is only applicable in conditions like this, where you have a external dipping which is happening. And wall thickness, so any uterus will have myometrium, so we can measure wall thickness in all the cases, which is कि जो mucosal surface है endometrium and the serosal surface दोनों के बीच में कितना distance है. तो typically हम कैसे ले सकते हैं? Actually it's freezing in this also. I have started writing, so it is not going back and forth. ठीक है, so once we have taken the 3 measurements in the previous slide that we discussed, इसके बाद there is one thing which we take the indentational angle. That means जो endometrium है उसमें कितना splaying present है. As you can see in this simple diagram, हम एक angle measure कर सकते हैं. And this angle guys, ये angle ऐसा है जो कि हम HSG में भी measure करते हैं. We can measure this in HSG also. And then we have the typical criteria कि अगर acute है around 75 degrees, then you call it a septate, and if it is more divergent, then you call it a biconuvate. So that is the indentation angle. Very simple. Okay. After discussing these things, now we come to the important classification systems. This is like a timeline. तो just see 1946 में पहला classification propose हो गया था. Today we are in 24, so there's a long way. You don't need to remember any of these less important ones. We just have to focus on 2 things: the American and the European. This is happening in everywhere, right? We have the American society and then we have the European society. So American वाले का जो latest version है, that is called as the ASRM, American Society for Reproductive Medicine 2021. They gave the latest version, which is really on fire. And then there is this European group which is called the ESHRE. उन्होंने भी एक काफी अच्छा classification propose किया था in the year 2013. So this is the timeline as we can see. So firstly we'll take up the ASRM. जो American Fertility Society था उसी का later on new and improved version है हमारा ASRM. इसमें typical 7 classes हैं जो कि हम NEET PG के time we used to study this itself, starting from hypoplasia, then uniconuvate, didelphus, biconuvate, and 7th class which was the DES drug related. Okay, so this is the typical NEET PGMA that we studied, but right now we have many more advanced classifications with us. So this is the AFS and the old ASRM. Now the latest ASRM is the Mac version 2021. Why this is so distinct? Number one, because इसमें no longer we have any numbering. Eshrei में we have some numbering which becomes a little difficult to remember. Here there is no numbering. Number two, it is applicable in a web application. ठीक है? और साथ ही में they also have a PDF that we can download, and offline also we can look at this entire thing in the PDF form. They have kept their original line diagrams, which make it really simple to understand. They have also included cervix and vagina anomalies along with uterus. And what this Mac version tells you that these Mullerian anomalies is actually a continuum. So just imagine 4 weeks tha, then 6 weeks tha, then 8 weeks tha. So it is not that at 4 weeks only the hit will happen, or at 6 weeks only. The hit can happen in between also at 5 weeks or 5.5 weeks. So it is like a continuum. It is like an spectrum. Okay, so this understanding is very important. Apart from that, there can be overlap between categories. So I'll tell you that there is a new entity which has been recognized, and it is called as bicornuate septate. जो दो anomalies में हमें सबसे ज़्यादा doubt होता है. Today there is a entity which is called bicornuate septate. Means it is bicornuate also, and there is a septum also. It is possible because there is a lot of overlap, and everything is in a spectrum or a continuum. Okay. So this is just the user interface. You can go through this in your own mobile phones. They have a QR code also. You can scan that. You can download their PDFs. A lot of diagrams, a lot of open-ended things, a lot of possibilities. Okay. So we don't have to force fit anything into one category. You can give the description. They have included everything: MRI findings, HSG, ultrasound, and a lot of images, including all the modalities have been covered, angle measurements, distances, everything you can get here. You can look at the symptoms, examination, differential diagnosis. Then they also tell you about the treatment, the medical treatment guidelines, surgical treatment guidelines for any particular anomaly. ठीक है, so ये जो MAC 2021 है, they have 9 anomalies in total, and this is their entire interface, which is quite user friendly. Understood? So 9 anomalies are there in the MAC 2021, and their anomalies are based on the embryology. कि सबसे पहले Mullerian agenesis होता है, and सबसे बाद में you have the subtle anomalies like an arcuate uterus. Understood? So anytime you have a doubt कि कौन सा क्या था, so ASRM is according to embryology. So class 1 will be Mullerian agenesis, and then you have the less severe forms coming later on. But if we talk about the European group, इधर पे it is exact ulta. The U0 is the normal uterus, and U6 or U5, then they have the severe anomalies coming later on. So ESHRE is the European Society of Human Reproduction and Embryology. While ASRM is based on the normal embryology, ESHRE is based on the clinical prognosis and severity. So U0 is normal and U5 is aplasia. ESHRE has total U0 to U6 for uterus. Similarly, C0, as you can see here, है ना, this is U0 to U6, and इसमें important thing to note is जो U6 variety है, it is unclassified. So they also have room and space that you can come across these rare anomalies which will not fit in any one bracket. You can assign a score of U6 in these cases. And this is a big realization. This is a mature way of thinking. Because as I told you, the embryogenesis is also over a wide spectrum. There is no white and black. There are a lot of shades of gray in between. ओके, तो ये इसका यूटेराइन अनोमलीज का एक पिक्चर है. इफ यू वांट यू कैन टेक अ स्क्रीनशॉट, अदरवाइज डाउनलोड दिस एंड यू कैन स्टिक इट इन योर यूएसजी रूम्स, ताकि तुरंत व्हेन एवर अ केस कम्स, विदाउट डाउट, विदाउट अ कंफ्यूजन, यू कैन कम बैक टू दिस. दिस इज द एंटायर कॉम्प्रिहेंसिव थिंग. तो यूटेराइन अनोमलीज, cervix में we have C0 to C4, and vaginal में also we have V0 to V4. Okay, so we start with normal uterus, which is 0. 1 is dysmorphic, 2 is septate, partial and complete. The 3 is bicorporeal, and you can look over here. There's partial, there is complete, and there is bicorporeal septate. Then we have hemiuterus, which is like unicornuate with rudimentary horn, without horn, aplasia, and then we have unclassified. वैसे cervix में normal, septate, double cervix, unilateral aplasia, and complete aplasia. And similarly, the vaginal anomalies like normal, longitudinal septum non-obstructing, longitudinal septum obstructing, which is V2. V3 is a transverse vaginal septum and V4 is a longitudinal. Okay, इसके बाद एक क्यूमे ग्रुप हुआ, that is called the congenital uterine malformation by experts. So because Eschere में भी कुछ चीजें थी which were not up to the point, so there is always scope for revisions and improvements in medical science. So we had a connuta group of experts. They proposed this classification in concordance with Eschere, and this revised thing is now called congenital uterine malformation by experts, the QMA classification. Okay. So till now, what have we discussed? The why, the embryology, the toolkit, dimensions for life, and the classification systems. Now we will take each type of anomaly one by one. So firstly, we have the U0. What is U0? This is the normal uterus. तो क्या क्या होता है इसमें? सबसे पहले external means fundus. So the external fundal contour is convex. The interosteal line is going to be straight or slight dipping is allowed. Don't worry. Endometrial cavity, as you can see in this diagram, it is triangular in shape. And both the tubes have their interstitial segments. Internal indentation in the fundal midline less than 50% of wall thickness is permissible. मतलब a little bit of endometrium can dip, but the fundus or the serosal surface will not dip. So external means fundal contour, external indentation, that will be convex. Internal means the endometrium. Endometrium can have a subtle dipping, or it will be absolutely straight, no dipping. Both things are possible. Okay. This is U0. Then we have class 1. क्लास 1 में क्या है बच्चों कि इसमें सिर्फ थोड़ा सा शेप उसका डिफॉर्म्ड हो सकता है, तो डिसमॉर्फिक यूटरस. इसमें भी there are 3 things, A, B and C. A is a T-shaped uterus, B is infantile, and C is all the other things. Again, they have kept things open-ended. ठीक है, तो what is a T-shaped uterus? Endometrial cavity कैसी होती है? It is narrow in the shape of a T. Lateral walls कैसी होती हैं? The lateral walls, as we can see in the image, the lateral walls are actually thick. Okay, the lateral walls are actually thick. So because we have these thick lateral walls, they will indent upon our cavity, and the cavity will become narrow, and the lateral walls are quite thick and stout. What about the uterus to cervix ratio? It is normal, that is 2:1. And what about the external fundal contour or the fundus or the serosal surface? It is again convex. तो सिर्फ एक चीज problematic है, that is the shape of the internal thing, that is the cavity. It is becoming T-shaped because there is lateral indentation from the lateral uterine walls. This is T-shaped. Now in your viva, they can ask you, is there a secondary T-shaped uterus also possible? It is possible. Anytime any distortion is happening, so because of adhesions, because of TB and adenomyosis, in sub you can get a secondary T-shaped uterus. So this is class 1A, that is T-shaped uterus. Apart from T-shape, you can have so many shapes here, a T-shaped, a Y-shaped and an I-shaped. So we can look at all 3 of the variants. अब क्यूमे ने गाइडलाइंस दी हैं फॉर अ टी शेप्ड यूटरस. वेरी सिंपल. एक एंगल है lateral depth है if it is more than 7 mm, and there is a T angle if it is less than equal to 40 degrees. So lateral angle which is less than 130, a lateral depth because lateral wall was thick, so lateral depth should be more than 7 mm, and then a T angle which is equal to less than 40 degrees. If you're getting all three criteria fulfilled, you call it as a typical T-shaped. What if in this case we got इसमें थ्री में से टू क्राइटेरिया तो फुलफिल हो रहे थे, बट जो lateral wall thickness थी that was not 7 mm, that was something around 4 mm. So 2 out of 3 criteria, what do we do then? This is a dilemma. We call it as a borderline T-shaped uterus. So this is the mature understanding. You will not get all the time typical anomalies. We have more things like this, a lot of exciting cases in the coming slides. Okay? So this is a borderline T-shaped uterus क्योंकि 3 में से 2 criteria were getting fulfilled. Acha, now we all love shortcuts. Like in physics, we just wanted shortcut formulas so that we don't have to, go through that pain of understanding. So here also I have searched for one shortcut for us. That is called as the rule of 10, which is for T-shape. So T-shaped में rule of 10 apply होता है. इसमें भी सबसे पहले आप draw करोगे अपना वही चीज, interostitial line. उसके 10 millimeters below, you will measure what is the thickness of the endometrium. Below 10 millimeter, if it is 10 mm or less than 10 mm, that means it is a T-shaped uterus because you have a narrow endometrium. So 10 mm below the interostitial line, if endometrial thickness is 10 or less than 10 mm, it is very much very highly likely that it will be a T-shaped uterus. Otherwise, you can see the second case, it is appearing like triangular. It was coming more than 10 mm. That was classified as normal uterus and not a T-shaped uterus. Lower down image में हमें देखते हैं कि there is hysteroscopic remodeling because जो T-shaped uterus है, it can have a poor pregnancy outcome. So we just have to go, थोड़ा सा margin of safety लेते हैं and we resect that extra uterine wall very safely, keeping margin of safety, and then we can transform that cavity from a T shape to a normal triangular shape which can house the fetus. These are other variants, I-shaped and Y-shaped. So if it is I-shaped or Y-shaped, the two ostia, the two openings of the tubes will be really close to each other and the interostial distance will keep on decreasing. I-shaped mein to there will be very less interostial distance as we can see in these images. Okay, so 1A was all this dysmorphic T, I and Y, all these different shapes. 1B is my infantile uterus. So infantile uterus में क्या होता है? There is a reversal of uterus to cervix. Normally, uterus to cervix is 2:1, but infantile में it will be opposite. 1:2, a short uterus and a longer cervix. So that is the infantile variety. 1C में all the other entities, subtle abnormalities, just like you have your arcuate uterus in ASRM classification, उसको आप एशर में कहाँ डाल सकते हो? You can keep it in 1C. Okay, so arcuate uterus में just remember two things. There is a little bit of indentation, very subtle indentation which is happening. So indentation का जो depth है, that is less than 1 centimeter. Septate में it will always be more than 1, just 1. The number 1, which is the easiest number to remember. Arcuate less than 1 centimeter indentation. Septate more than 1 centimeter indentation. And angle में, septate is usually acute angled. And arcuate will be really broad. It will be obtuse angle, more than 90 degrees. So this is the thing about 1C also. With this, we have completed class 0, that is normal uterus. Class 1, which was all kind of very subtle abnormalities, T-shaped, I-shaped, arcuate, infantile. Now we come to a little bit, serious thing. That is your U2, that is septate uterus. Septate में two possibilities are there. 2A is partially septate and 2B is complete septate. And this we can see beautifully in these illustrations also. यहाँ पे हमें मोटिवेशन मिलता है. I've shared a handmade diagram with you. This is a really senior consultant and when he gives off reports, he ensures कि he has made a handmade diagram that increases the credibility of our reports. ठीक है? So every time try that you just make a quick handmade diagram and give the important measurements in your report, such as the wall thickness, internal indentation, and septum का कितना length है, septum का कितना thickness है. This will change the game for you. This slide is one really cool slide. I've tried to compile all the guidelines and what everyone has to say about septate uterus. AFS में क्या होता है, ESHRE के according क्या होता है, ASRM, QMA, and the latest ASRM also. So try to take a screenshot of this slide and keep this with you. Whenever you are in confusion कि क्या बनाए, septate है या नहीं है, you just come back to this slide. We have all the societies and what is their criteria for a septate uterus. This is again the three most जो सबसे ज़्यादा हमारी फेमस सोसाइटीज़ हैं, हमारा ASRM अमेरिकन वाला, एशरे दैट इज यूरोपियन, एंड क्यूमे. इन तीनों की एक सिंपल डायग्राम की मदद से वी हैव all the things remember in one spot about septate uterus. But this is a better thing, is much simpler. So take a screenshot of this and all the societies and their guidelines about diagnosing a septate uterus. This is the same thing in the diagram form. Okay, fine. So these are some more cases of partial septate uterus because the septum is not reaching up to the internal os. This is a complete septate uterus, and we have a handmade diagram also where we see that the septa is also reaching in the cervical canal. So we have U2B, that is a complete septate uterus, and C1 because we have a septate cervix as well. So this is another example. Septate में lot of times we have to do an MRI even if we are confident on a 3D scan, because we have to tell them कि septa कैसा है. Is it fibrous, muscular or fibromuscular? Because that is actually the most important thing that will decide whether we can resect it, is it safe or not. And apart from all your measurements, septal length, septal thickness, and the uterine wall thickness, all of those typical measurements. This is another case of complete septate uterus and septate cervix also. इसमें VC के बीच में there is a little bit of deficiency. So that also sir has shown in a handmade diagram. The two cavities are connecting lower down. So MRI, which can very easily tell us if it is a fibrous septum, T1, T2 पे hypointense, and if it is a muscular septum, it will be iso-intense to the muscle wall. This is a hysteroscopic resection, which is called meteroplasty, your septal resection, and how you can beautifully transform a septate uterus into a normal endometrial cavity, which will help to house the fetus. And the patient delivered a full-term pregnancy. So this is the beauty of medical science. Acha, this is a really interesting case, relatively new entity introduced हुई है, which is called as Robert's uterus. So what is Robert's uterus? Anyone? Have you seen these cases in your OPDs? Anyone, anytime? This is not very common actually. It is a rare entity. And it can really confuse us into thinking, what is this happening? Is it bigonoid? Is it didelphus? Is it Ovira syndrome? God knows what. So what is Robert's uterus? It is a type of septate uterus, asymmetric septate. Normally septate में क्या होता है? The septum is midline and it is dividing the cavity into 50% and 50%, एकदम symmetrical, midline. But here, Roberts may we have a asymmetrical uterine septum. So there is one cavity which will get obstructed. So in the diagram, we can see an obstructed hemicavity and a non-obstructing hemicavity because of Roberts uterus. MRI image of the same. Okay. So because we are discussing septate, so with septate, there are so many things which we confuse, that is normal and arcuate. We will keep coming to this in the later slides as well. But just to keep in mind, septate can be confused with normal and with arcuate. This is arcuate. We have already discussed what is arcuate. Type 1C of ESHRE is arcuate uterus. Now we come to U3, which is bicorporeal. So bicorporeal can be partial, complete, or C wala, which is bicorporeal septate. Okay, so type C, I think, is the most interesting right now to everyone, that an entity like this can exist. Yes, it is possible. So these are our cases. ऊपर जो images हैं, these are showing us as partial bicorporeal uterus, and there is a pregnancy in one side of the hemiuterus, and then you have a complete bicorporeal uterus as well. And how beautifully handmade diagram say we can depict the same. Okay. The class will be till around 9:30. Okay. This is a case of bicorporeal septate. So see, because there is some external clefting also which is happening, which is fulfilling the criteria given by Escher, and a septum is also present, which is dividing the two cavities. So it is bicorporeal septate uterus. I want you all, after this session, just go back, read more about this. It's a really interesting entity. The next thing, possibility in bicorporeal, one can be bicornuate and one can be didelphous. So didelphous means, now I will show you very simple thing. Always remember that whenever Mullerian anomalies, we have these two hemiuteri, okay, and then the cervix and the vagina. So if they are widely divergent, so this is my didelphous, and of course it is heart shaped. They are so distant, they are so divergent. Without a doubt, it is didelphous, heart shaped. Lot of external clefting is happening. So this is didelphous. एक step आगे थोड़ा सा फ्यूजन हुआ, लोअर डाउन दे आर पार्टली फ्यूज्ड, but ऊपर they are still divergent, and you get this heart shaped thing. Heart shaped fundal clefting, external indentation, and of course internal indentation as well. इतना ज़्यादा external indentation है तो cavity को तो indent करेगा ही, पर नीचे से it can be partially fused also, and the cavities are relatively close to each other. Didelphous, bicornuate. And then what is septate? Septate is like this, that we have discussed. The two cavities, दोनों के बीच में बस एक कॉमन वॉल है जो कि प्रॉब्लम क्रिएट कर रही है. बाहर से एक्सटर्नल कॉन्टूर कैन बी नॉर्मल, कॉन्वेक्स और इवन फ्लैट, बट इट विल नॉट बी हार्ट शेप्ड. So didelphous, bicornuate, and this is my septate. Two cavities separated by a septum in between. External contour is going to be flat or even convex. Okay. Didelphous, bicornuate, and septate. So this is didelphous. Acha, इसमें we think that didelphous means two uterus, two cervix, and two vagina. But there is a big catch. So one of my OBG consultants, they just told me that it is actually one single vagina. But there are a lot of them, almost most of them are actually associated with longitudinal or transverse vaginal septum. And this is the reason you have a septate vagina, but you don't have two separate vaginas. That is a catch in didelphous. So two separate hemiuterus, two separate cervix, yes, and really divergent cervix. Cervix के बीच में भी काफी distance रहेगा, at least more than 10 mm. And the vaginas, there will be one vagina which will be septate, longitudinal, transverse, or both septa might be present. And this is the reason that one of the varieties of didelphous presents with the Ovira syndrome, obstructed hemivagina syndrome, because they are so commonly associated with vaginal septums. So didelphous plus obstructed hemivagina plus renal agenesis on the same side is your Ovira syndrome. This is again a beautiful handmade diagram for a didelphous uterus. Yeah, for sure, dear. Bicorporeal में there will always be external indentation. And just imagine, इतना ज़्यादा external indentation है तो internally तो cavity को indent करेगा ही करेगा, है ना. सेप्टेट में एक्सटर्नल इंडेंटेशन ऑलमोस्ट ना के बराबर होता है. नो एक्सटर्नल इंडेंटेशन, ऑलमोस्ट फ्लैट और इवन कॉन्वेक्स. But bicornuate and didelphous will have a lot of external indentation. बाहर से ही it will appear like heart shaped, two separate cavities. ठीक है. External means serosal surface or fundus. Internal means cavity or endometrium. Now the U4 is unicornuate. इसमें rudimentary horn may be totally absent or present, and then all kinds of possibilities. There is functional endometrium. Then it could be communicating, non-communicating. तो यूनिकॉर्नुएट को आप HSG में भी कई बार डायग्नोस कर लेते हो, बट एक कैच होता है दैट इफ यू हैव कैन्युलेटेड ओनली वन साइड ऑफ डाइडेल्फस, that can also look like unicornuate on HSG. It is always important to be sure with your 3D ultrasound or MRI. So this is our unicornuate uterus. There is a functional cavity which is partially communicating as well. This is our typical unicornuate. Now we have aplastic, means uterine aplasia. Complete everything is absent. No uterus, no tubes, only ovaries are present, है ना? And maybe a blind vaginal pouch. That is complete aplasia. MRKH syndrome. Sometimes there may be some remnants present also. So it could be complete or it could be partial aplasia. Everything is a spectrum, guys. You can have so many permutation combinations possible. Escher tells us that as many as 36 permutation combinations are possible actually. ठीक है. Now the saga of septate. फटाफट septate के बारे में थोड़ा सा discuss करते हैं because this is number one, the most common and lot of times the most confusing also. So this is light yellow color में जो दिखा रहा है, that is the actual people who actually have septate uterus. And if you look at Escher, it is far more over diagnosing. And ASRM, American, they are under diagnosing. European, they are over diagnosing septate. That means normal and arcuate also Escher may classify as septate. And just imagine if you go on and resect the myometrium of a normal or arcuate uterus, can cause a lot of adhesions and poor prognosis later on. So Escher over and sometimes misses septate uterus, and patient keeps going on and having these recurrent abortions. So this is the reason that this slide is so important, that you don't have to be like, I'm loyal, I will only use ASRM. No. If you are having a problem, आपको confusion हो रहा है, तो आप ASRM को छोड़िए, दूसरे guidelines use कीजिए. You can use a CUM guidelines because ASRM is under and Escher is over diagnosing. CUM is like the middle ground. So CUM क्या बोलता है कि septal thickness should be at least 10 mm. That means 1 centimeter. We discussed 1 centimeter, one figure of 1. Arcuate uterus less than 1 centimeter, and septate means the septal length of at least 1 centimeter or more than that. Angle can be quite divergent. That means 140 degree or less than that. And then the internal indentation to the wall thickness ratio of more than 110%. Okay? So this is very simple. I will tell you the crux of this. क्या होता है कि ASRM assumes that the septum should be thin and long. So it should be long and thin septum. Okay? Long and thin septum. But Escher thinks it can be a really short and broad septum. This is the reason arcuate को भी वो septate बना देता है. Q में is the middle ground. Q में बोलता है कि septum should be at least चलो 1 centimeter in length, but it could be a broad spectrum also. So it could be 140 degrees तक divergent. ASRM says that septum will be long, really long and thin septa. Escher says it can be really short and broad. Q में tells a middle ground. 1 centimeter तक हो सकता है, and it can be broad as well. That means less than equal to 140 degrees. Even then you have to place it as a septate variety. Acha, this is your cervico-vaginal anomalies. See, bicorporeal means anywhere you have two different bodies. Corpus means bodies. Okay, so didelphus में तो they are completely separate. पूरा दो separate uterus, दो separate cervix और vagina में भी septum present है, completely different. So that is also bicorporeal. And bicornuate is also a kind of bicorporeal because उसमें भी lower down there is a little bit of fusion, but otherwise the major portion and the superior portion of the two uterus, they are widely separated with interostitial distance of equal to more than 4 centimeters. तो डाइडेल्फस तो डाउट ही नहीं होता, इतना दूर दूर दोनों पड़े हुए हैं. बाइकॉर्नुएट भी बाइकॉर्पोरियल होता है जिसमें पार्शियली थोड़ा सा फ्यूजन हो गया है. तो बाइकॉर्पोरियल में डाइडेल्फस एंड बाइकॉर्नुएट बोथ आर प्रेजेंट. सर्वाइकोवैजिनल एनोमलीज, यू कैन सी सर्विक्स में सेप्टम मिल सकता है या ड्यूप्लेक्स सर्विक्स मिल सकते हैं, एप्लेजिया मिल सकता है, and then similarly vaginal anomalies as well. Okay. Now comes this and that. Oh my god. लॉट ऑफ कंफ्यूजन हैपेंस, है ना? क्या क्या कंफ्यूजन होता है, एवरीवन नोज. दिस इज सो क्लोज टू माय हार्ट बिकॉज वी कीप फाइटिंग विद दिस ऑन अ वेरी फ्रीक्वेंट बेसिस. सेप्टेट है या आर्कुएट है. समटाइम्स एशरे तो नॉर्मल को भी सेप्टेट बता रहा है, उसकी तो इतना सेंसिटिव है वो सेप्टेट के लिए दैट इट इज ओवर डायग्नोजिंग नॉर्मल यूट्रस एज सेप्टेट. सो सेप्टेट का आर्कुएट के साथ या इवन नॉर्मल के साथ. सेप्टेट है या बाइकॉर्नुएट है. Then there is a new entity called accessory cavitated uterine malformation, ACU. Sometimes it looks like it is a rudimentary horn in a unicornuate variety. तो ये एक चीज कंफ्यूज कर सकती है, this versus that. And sometimes not very common, but sometimes didelphys versus bicornuate bicollis, because now bicornuate bicollis also has what. See, didelphys may there are two separate cervix which are widely separated. At least 10 mm means 1 centimeter or more they will be separated in didelphys. Bicornuate में the two cervix will be very close, around 3-4 mm का distance होगा. बीच में there will be a septum. Okay, so usually bicornuate will have a septate cervix. It will appear like there are two cervix, but it is actually one cervix which is having a septum. Didelphys will always have two duplicated cervix. So that is the distance. And और चीजें भी हैं, we'll come to that right now. Chalo. So this is showing us that there was a lot of confusion around septate uterus in the year 2016-17, lot of misdiagnosis. Normal को आप septate समझ के resect कर रहे थे myometrium को, and septate को आप miss कर रहे थे American Society के हिसाब से, and you were missing those patients and they were still having really poor pregnancy outcomes. A lot of issue was happening. This is the reason Cume came like a peacemaker, है ना? So it is having some points of ASRM American, and it has taken some points which are like Eshere, that is European. ठीक है, देखते हैं कैसे. अब इस स्लाइड पे फिर से एक बार आ जाइए. This is so important. So ASRM is saying a septa should be at least 15 mm, means 1.5 centimeter. It should be a really long septa. Eshere and Cume both say that septa should be 1 centimeter, not that long. Short septa can also be present, very much possible. So ASRM was saying you should have long septa. Eshere and Cume, they say you can have medium septa or short septa also. 10 mm tak bhi ho sakta hai, 1 centimeter. If it is less than 1 centimeter, to it will become arcuate. But 1 centimeter or more, then it is a real septa. At least 1 centimeter. ASRM was saying at least 1.5 centimeter. तो ये एक डिफरेंस था. क्यूमे एंड एशरे बोलते हैं कि 1 सेंटीमीटर का भी है तो चलेगा. ASRM was saying strictly that at least 1.5 centimeter or longer, only then I will recognize it as a real septa. Okay, and then angle था कि ASRM was like the angle should be less than 90 degree, means acute angle. The septa is long and it is thin. But Eshere was saying that septa can be really divergent. So Eshere ka angle was divergent, and Cume ka angle is also obtuse, means less than equal to 140 degrees. It is saying that even that can be septate. So you can have long and thin septa, you can have short and broad septa also. That is the crux of this entire slide, and just take a screenshot of this with you. Okay, and one more beautiful thing was in QMA, we always know that ratio are better than absolute values. So if you take internal indentation upon wall thickness ratio, and if that is coming more than 110%, so you can safely classify it as septate. So next time, whenever you are reporting in your case and you want to classify it as a septate, so you just mention that according to the QMA criteria, the septal length equals to this much, septal angle equals to this much, and the internal indentation upon wall thickness ratio of this much. So in accordance with the QMA criteria 2018, the above anomaly is a septate uterus. So you can mention in your reports, that will make them really credible. This is our HSG pay. We all. So this is septate versus bicornuate. HSG pay, what is the criteria? In one slide, everything put together. ASRM, Eshere classifications, then the treatment. Septate uterus में nothing big, just go on and resect the septum. Whereas in bicornuate, it is having a much better pregnancy outcome. ठीक है, कंपैटिबल विद अ नॉर्मल प्रेगनेंसी। नाउ गाइस, ये भी एक शॉर्टकट है, जैसे मैंने टी शेप यूट्रस में एक शॉर्टकट बताया था, द रूल ऑफ 10। दिस इज अनदर लाइफ सेविंग ट्रिक आई विल टेल यू टुडे। आफ्टर अ लॉट ऑफ सर्चिंग आई गॉट दिस थिंग कि सेप्टेट और बाइकॉन्वेट में हाउ कैन वी डिफरेंशिएट। So just that simple thing, always which we start, it is our interosteal line. So you draw your interosteal line. If the fundal cleft is crossing that line, means it is quite deep, or it is within 5 millimeters of that line, it is without a doubt a septate, bicornuate uterus. And if my external fundal contour is equal to more than 5 millimeters from my interosteal line, that means it is a septate uterus. फिर से I will repeat, this is a shortcut method. Draw the interosteal line. If the fundal clefting is crossing this line, it is deep enough, or within 5 millimeters of this line, without a doubt, it is for sure bicornuate. If the fundus is present more than 5 millimeter away from the interosteal line, that means it is a septate variety. So you have to look at the external indentation or the fundus or the uterine contour. इंटरनल इंडेंटेशन का कोई रोल नहीं है इस ट्रिक में, ठीक है। क्योंकि देखो आप, इंटरनल इंडेंटेशन कैविटी तो तीनों डायग्राम्स में हार्ट शेप की दिख रही है, तो इंटरनल इंडेंटेशन विल नॉट हेल्प अस. व्हाट हेल्प्स इज एक्सटर्नल इंडेंटेशन. बाइकॉर्नुएट हैज अ लॉट ऑफ डिपिंग गोइंग ऑन, वेयर सेप्टेट हैज लेस ऑफ डिपिंग और नो डिपिंग एट ऑल. सो एक्सटर्नल इंडेंटेशन. Now, we can have a doubt here, na? Agar if it is didelphus versus bicornuate bicollis. So I told you any day didelphus may the two hemiuteri will be much more divergent. Similarly, they will not show any communication with each other at any point of time, anywhere. No communication, widely separate cavities, divergent cavities. Even the two cervix will be widely separated more than 10 millimeter distant. But bicornuate uterus में there will be most of the cases में partially communicating. Lower portion में they will be still fused. They will be communicating with each other. And even if it is bicollis, the two cervical cavities will be present near, very close to each other, less than 5 millimeter distance. ठीक है? Thank God the power supply is there. So didelphus में क्या करना पड़ता है? You might have to go for surgical interventions. Bicornuate is compatible with a normal pregnancy. ठीक है. So prognosis of bicornuate is better than septate, and prognosis of bicornuate is better than didelphus also. ठीक है. तो कुछ pain points है. We are just coming toward the end of our session. Pain points में, as I told you, there is an acum, which is accessory cavitated uterine mass. It is not an adenomyoma. It is not a rudimentary horn of a unicornuate uterus. It is a separate entity. There is normal uterus, tubes and ovaries. So it is a rare thing. Anytime, maybe once or twice in a lifetime, you will come across this. So at that time, remember that we had discussed this rare anomaly in our session today. ठीक है. ये एक और anomaly है जो बहुत मुझे fascinating लगती है, bicorporeal septate. That means there is heart shaped dipping also, but if you see inside, there is a septum which is further separating the two cavities. तो external clefting भी है और internally भी there is a septum which is separating the two endometrial cavities. So bicorporeal septate. So इसके बाद we come to the approach में, this is a simple algorithmic approach which is given in a radiographics article. So you can go back and read this very simple 6-step method how you have to approach any case of Mullerian anomalies. And if you want, you can take a screenshot here and remember this next time when you are confronted with a case. Okay, now comes a really significant thing, that how do we do the reporting? Okay. So some important points to be kept in mind. Just give the description. It is not important to force fit it into one particular category. Just give your description very coherently. Second thing, look at the uterus, the cervix, as well as the vagina. All three things to be noted. Septaka always give at least two measurements, the length and the width, and characteristics characterize this. Is it fibrous? Is it muscular or fibromuscular? Rudimentary horn ka always look if there is a communication or not, and is it functional or not. In these things, a lot of times MRI helps more. Okay, in septa and in cases of rudimentary horn. Measurements may be very strict when it comes to measurements, but be cool and open minded when it comes to force fitting it into one particular category. It is not always कि हर anomaly में you will be able to assign a category. Sometimes you can keep things open ended. Just give your precise description, give all the measurements, and make a handmade diagram. Report will be very much appreciated. ठीक है, so कुछ measurements थे जो कि हम एक बार में इंटरनल इंडेंटेशन, दैट मीन्स कैविटी कितना डिप कर रही है, एक्सटर्नल इंडेंटेशन, वॉल थिकनेस और मायोमेटेरियल थिकनेस, द एंगल विच इज देयर, इंडेंटेशन एंगल, and only in cases of T-shaped uterus we measure the lateral wall thickness also. ठीक है, ये सर्जन को हेल्प करता है सारे मेजरमेंट्स टू डिसाइड द मार्जिन ऑफ सेफ्टी. मल्टी मोडालिटी अप्रोच एनी डे इज अप्रिशिएटेड. MRI, when will you indicate an MRI? Septum means septate uterus. Blood, that means unicornuate or rudimentary horn. Functional endometrial cavities there or not. In all those variants, MRI will be a problem solver. Then associated things will happen in Mullerian anomalies. So adenomyosis, endometriosis, fibroids, polyps. Other anomalies means renal, skeletal, etc. Post procedure also, a lot of times they will do septal resection and they send the patient again to see post procedure what is the status of the cavity. Diagrams if you make, it is very much going to complement your report. And then finally impression mein, if you are able to put it into one category, to you say that okay, according to QME criteria 2018, this is classified as septate uterus with septate vagina or whatever. If you're not able to put a particular final impression, no problem. You keep your report descriptive and don't force fit ever. Okay, so these are some sample reports of really established senior consultants, and you can see a lot of them, they prefer giving these diagrams along with their reports. Simple handmade labeled diagrams and very to the point descriptive report, no storytelling. Acha, so what do you guys say? If you want, we can have a mini quiz, or we can totally skip that. Whatever you say. The session is over. Small mini quiz is there. If you guys want, tell me. Everyone wants? चलो जल्दी से करते हैं, बिल्कुल फटाफट करेंगे, ठीक है? या सो दिस इज केस नंबर 1. इसका सोनो इमेज है. यू कैन सी एक ये चीज है, ठीक है? आई एम जस्ट हेल्पिंग यू क्विकली. एंड एक ये चीज है. So there is one thing here, one kind of cavity. There is something else also. Okay. Sajide image. MRI पे it will be more helpful. देख लेते हैं. Any answers? Okay. Biconvate would be a little close, but something else. Yes, I'm getting you're near the correct answer. Yes, absolutely. So can you be a little more precise? What kind of horn? Is it functional or not? And is there any communication, if you can appreciate in these selected images? Functional endometrium and communication. Very good. Absolutely. Lovely. There is functional endometrium. क्यों? क्योंकि endometrium functional होगा, मतलब there some kind of menstruation will happen. So T1 में the blood products will be hyper intense, है ना? And they will not suppress on fat suppressed images. So they will be bright on T1, may be bright or not depending on the what kind of blood products are there, how chronic they are. But T1 pe usually they will be bright, and here also we see that T1 images it is bright, and in the second image number B, on a fat suppressed image it is not suppressing. So T1 bright could be fat, but we have made sure it's not fat. These are blood products, so it was a functional endometrium which was not communicating. So uniconvate uterus with a functional endometrium and a non-communicating horn. Absolutely correct. इसका differential diagnosis क्या बन सकता है? Acum. उसमें भी हमें लगता है there is a separate thing. But this is a very typical case of uniconvate with functional non-communicating horn. Absolutely correct. ठीक है. Now we come to the next one. ये इसका सर्जिकल इमेज था. So this is actually, the smaller arrow is the normal unicornuate uterus, and this is the rudimentary horn which seems to be distended with chronic blood products, and then it was resected out. Chalo. This is really simple. Yes. So these are the images, and then we have some stir images also. Any guesses? What can this be? You can look at a pelvic kidney. There is associated renal anomaly. And we actually do not appreciate anything like a normal uterus over here. Absolutely correct, Dr. Madhvi. This is MRKH syndrome with a pelvic kidney. We do not see any uterus there. All this is your vagina. There is a long atretic vagina. There is no uterus and other components like a cervix. There is a pelvic kidney. And in the stir image also, what we see here is the two ovaries on both sides, right and left, which are normal. Because MRKH syndrome mein, ovaries gonads are coming from genital ridge, so they will be present. Morphologically they will be normal, even functionally they are little suboptimal, but morphologically the two ovaries are normal. What we don't find is the Mullerian duct stuff, that means uterus, tubes, all of that were absent, and a pelvic kidney was present. So this was our MRKH syndrome. Okay, bilateral complete Mullerian agenesis with an atretic vagina and a pelvic kidney on the right side with bilateral normal ovaries. The last case, so this case recently we got in our department. I'll help you. These are the sono images. This is the right sided thing, okay? And this is the left sided thing. Left sided thing in the lower down image, the right sided thing. And then there is this dilated fluid filled structure, which is something getting obstructed. I will also show the MR images. These are our MR images. The last image, you also look at the kidneys. What do you think? Yes, yes, yes. So again, we have the answer. We see this is, guys, a didelphys uterus. क्योंकि जब हम uterus को देखेंगे, they are quite divergent. Then there was an obstructed hemivagina, and on the same side, that means right side, we see that there was complete right-sided renal agenesis. So didelphys uterus with right-sided obstructed hemivagina and left atretic vagina with right-sided complete renal agenesis. So this was our Ovira syndrome. So words of wisdom क्या है कि 3D अल्ट्रासाउंड को आप don't try to skip 3D ultrasound for an MRI, and that too with preparation should be the ideal thing. Description is more important than categorizing and force fitting into one category. All kinds of permutation combinations are possible in real practice. Always look out for associated anomalies. A multi-modality approach comes a long way, and be strict with measurements and cool with the categories. Okay. So that is all for today. I have left my contact details if you guys have any queries in the future. So anyone has any doubts? Any queries from anyone? Unfortunately, we had a bunch of technical glitches here and there. I wish that next time we don't have them. Otherwise, what do you guys, everything is, could you understand the topic, or any feedback that you would like to leave? Okay, nothing much then. So, should we end the session?